The Great Barrington Declaration, Krishna, is not actually all that original. It's the old pandemic plan. It's the same pandemic plan we followed for a century of respiratory virus pandemics. I think that the economic dislocation caused by the Indian lockdowns caused more devastation and death than the lives saved by delaying when people got COVID. It was partly the responsibility of these social media companies themselves, but I think that they were acting defensively. Like they were acting based on what the previous rounds of criticism they got for allowing too much free speech during, let's say the 2016 election or something. It's that we had this illusion of control. We think our science is so good, our social policy is so powerful that we can stop the tide from coming in. That's what it's akin to. We don't have the kind of control we think we have. I think those AI systems lower the cost of entry to becoming an excellent doctor. Just because it's a primary intervention doesn't necessarily mean that it's worth it.
Hello and welcome to another episode of the KVKurious Podcast. Our guest for today is Professor Bhattacharya, who is a professor of medicine, economics, and health research policy at Stanford University. Professor Jay is also one of the co-authors of the Great Barrington Declaration written during COVID times. In this conversation, Professor Jay speaks about his thoughts on how the world has navigated the pandemic, the economics of lockdown, what are some things we can do to prepare ourselves better in case of a future healthcare crisis or a pandemic? What are some things we can do in order to position ourselves for access to better healthcare, better education, and better lifestyle in general? In this conversation, Professor Jay also throws light on his Twitter ban and how he thinks government must have been involved in this entire process. Professor Jay is an active advocate of free speech, and he speaks a lot around how platforms can really improve in order to make free speech really happen across the world. So stay tuned with me. Listen to Professor Jay Bhattacharya on the KVKurious Podcast. Hi, Professor Jay. Thank you for being on my podcast. Super honored to be hosting you and looking forward to chatting more around healthcare policies, preventing future pandemics, economic impacts of healthcare, and much more.
Looking forward to it too, Krishna. Thank you for the invitation.
Sure. So it's been close to 3 years since the pandemic actually started. Where do you think as a world we are right now, and how do you think we've handled this so far?
Well, I think we are in a terrible place. We have paid tremendous costs and harms in lives and money for from the pandemic, from the disease itself. But also, I think many of the policies that we've followed have had a devastating effect on the countries of the world and the peoples of the world, especially the poor of the world. Huge numbers of people have been thrown into poverty as a consequence of the lockdown policies we followed, leaving people destitute, in many cases starving. Our healthcare systems have been shown around the world to be inadequate to the task of managing the stress of a pandemic, whereby we not only failed to protect people from the COVID itself, but also we forgot about a whole range of other healthcare priorities. There are big increases in mental health problems worldwide. There are big including depression, anxiety. There have been big increases in unidentified cancer, a huge backlogs in cancer screening. It's just, I think we are in a very difficult situation 3 years down the line, even though the risk from the disease itself has mitigated relative to what it was in March of 2020.
So you think the stress on the healthcare system is largely a snowball effect of not being able to handle the pressure 1.5 years down the line before?
I think so. I mean, I think if you look back to 2020, the mantra of public health was that that only COVID mattered, and all elective procedures. Elective procedures included essential things like vaccination of children for essential childhood diseases like against malaria, pertussis. Huge numbers of kids didn't receive those vaccinations around the world because public health decided to transfer the resources that went into that instead into COVID. In developed countries, healthcare systems essentially shut down. Although people saw stories of overwhelmed hospital systems when COVID waves hit, and that's true that a few were, the typical situation was that hospital systems in developed countries were empty, waiting for COVID patients most of the time, and they didn't do their essential functions, including cancer screening, diabetes management. A huge number of preventive care services were skipped. That has consequences, and we're paying those consequences now in terms of worse health, worse metabolic health, worse cancer, mortality, and then of course, as I mentioned, the backlog on the mental health problems that we now face is just tremendous. Huge numbers.
So, on some level, do you think the Barrington Declaration was overlooked, and maybe giving it more importance could have prevented us from getting here?
Yeah, so just to remind the audience what the Great Barrington Declaration was. So I signed. So I'm a professor in medicine at Stanford University at the time, and now I'm in health policy. Then I signed with Sunetra Gupta of Oxford University, professor of epidemiology there, and Martin Kulldorff, a professor at Harvard University, then an epidemiologist and biostatistician there. The three of us signed the Great Barrington Declaration in October 2020.
Yeah.
And what we were arguing for was basically two things. One was focused protection of vulnerable people. Now, what did we mean by vulnerable people? The harm from the disease, the likelihood of dying if you get infected, is exponentially higher for older people than it is for younger people. The risk of dying, the infection fatality rate overall is probably something like less than 0.2%, 99.8% survival. But that's very misleading. For young people, it's much lower than that. Especially for children, it's vanishingly low, whereas especially healthy children. Whereas for older people, it's much higher, 3, 4, 5% if you're over the age of 70, 80, 85 maybe. And so the right thing to do is use resources to protect older people when you have that risk floating around. When you have COVID floating around. So the Great Barrington Declaration called for focused protection of vulnerable older people. And for the rest of the population, especially for young people, it called for the lifting of restrictions, opening schools, allowing young people to essentially live their normal lives, with the logic being that the risk and harm from the lockdowns on young people's lives would be worse than the harm from COVID, which actually I think has turned out to be true.
Right. So largely you think it wasn't given enough importance.
Yeah.
And maybe paying more importance to it could have prevented us from getting here.
I think it was in most countries completely ignored. I can think of very few places that followed its principles, including Sweden is probably a preeminent example. Now I have to say, Sweden's strategy at the beginning of the pandemic, while it was along the lines of the Great Barrington Declaration, it actually failed in focus protection very early in the pandemic. There were a huge outbreak of cases in nursing homes in Stockholm very early in the pandemic, and so it wasn't following focus protection. But it adjusted, better protected older people, did not rely on lockdowns and draconian policies, more like just standard public health guidance. And the reason Sweden followed it is because the Great Barrington Declaration, Krishna, is not actually all that original. It's the old pandemic plan. It's the same pandemic plan we followed for a century of respiratory virus pandemics. And the fact that we failed to follow that plan is, I think, a key reason for the harms that we talked about right at the beginning of the podcast.
Very interesting. Since you brought the idea of telling that following the Great Barrington Declaration one of the core principles of this is, would I be wrong in telling that following herd immunity or building up to herd immunity? And if that is the case, do you think India did a better job in setting an example of how herd immunity can be achieved and preventing, further lockdowns beyond the first one?
Oh, the Indian policy is, unfortunately, I don't have a lot of sympathy for the Indian policy, I have to say, unfortunately. So I think first we have to talk about the first lockdown. That first lockdown was cruel, Krishna, cruel to to millions and millions of very, very poor people, especially migrant workers. The policy required essentially migrant workers, living in the big cities of India, to cease their work and go back to their home villages, where presumably, and the problem is, like many of those migrant workers, they live hand to mouth, right? Their entire inventory, their entire life's worth is wrapped up in their inventory, right? They buy mangoes or something and they sell them on the streets of Mumbai. And then when the lockdown hit, essentially they couldn't sell their inventory, and that meant that they starved, right? Their whole life savings, they sell the mangoes, they buy more mangoes for the next day, and they feed their family with money. That evaporated overnight for millions and millions and millions of very, very poor Indians in that first lockdown. And then the order to return to the home villages, the Indian transportation systems are not set up to manage such a large population migration. And so en route, the reports are that when tens and millions, all the hundreds of millions of people start using the trains and the buses and walking and biking along these routes, many of whom are not in physical condition to do that, especially the walking and the biking or crowded trains. 1,000 died overnight, immediately upon that order. It was a cruelty that was completely predictable, Krishna, and should have been avoided.
But what do you think, at least on the early stages, and when we're speaking of the first lockdown, I think we're speaking of April 2020, I think, which is 6 months before the Barrington Declaration was signed, and before we had much more clarity on what could be better mitigative measures. And when we're speaking at this early stage, what do you think could have been a better way to tackle this?
I think the Great Barrington Declaration, something like it, because it's the key thing about the Great Barrington Declaration, as I said, Krishna, it wasn't actually a novel policy. It was the standard policy that we followed before. What was novel was the lockdown. The lockdown is at such a scale and for such a long duration is unprecedented in human history. So I think if we just followed the standard, if India had followed something like the standard plan, what would have happened is that we would have avoided the lockdown harms that came from that April 20 lockdown, which paid primarily by the hundreds of millions of people who can't afford to lock down in India.
So are you suggesting that the number of deaths due to the economic consequences of lockdown is supposedly higher than the number of deaths that would have happened even if much of them were just let out in the public to move out there and get their regular routines going?
Yes, that's exactly what I'm suggesting. I think that the economic dislocation caused by the Indian lockdowns caused more devastation and death than the lives saved by delaying when people got COVID. So just let me give you some evidence on this, Krishna. So if there was a seroprevalence study done in Mumbai in July of 2020, seroprevalence means measurement of antibodies levels in the population. So the idea is that if you have specific SARS-CoV-2 antibodies, that's an indicator that you've had the disease and recovered. And so research groups in India worked to conduct massive seroprevalence studies around India in 2020. One, particularly in Mumbai, found that in the slums of Mumbai, that there was a 70% seroprevalence rate. That means 70% by July of 2020 had already had COVID in the slums. In the richer parts of Mumbai, the seroprevalence is something like 20%. So you can see that from there what the lockdowns actually did. What they actually did was they protected the class of people who could afford to work from home and not lose their job, while the vast rest of India essentially couldn't comply with lockdowns, because if they did, they would starve. And the problem was, like, the economic dislocation caused by the policy led to tremendous harm to those poorest people. So for instance, in March of 2021, there was a UN report that estimated that 238,000 children had died from starvation as a consequence of the economic dislocation of the lockdowns in India and in South and in Pakistan. And that's just March of 2021. The estimate worldwide is something like 100 million people were thrown into dire poverty, $2 a day of lesser of income. The policy of school closures, especially in India, was tremendously short-sighted, Krishna. So in many places in India, kids never went to school for 2 straight years. They're physically not present.
Yeah, and I think that must significantly have an impact on the kind of education that they picked up in those 2 years and how it in turn affects their career from there on.
But it's not just careers, Krishna. So if you look at the social science literature about why schooling is important, it's not just simply what you learn and the money you make in your job. It turns out that schooling is a tremendously good investment for health as well.
Okay, can you elaborate on that?
Yeah, so when kids miss school, it's very difficult to make, for extended periods of time, it's very difficult to make it up. There are like social science studies where they look at natural experiments, like one place extends the school year, required schooling by a year, and that tends to increase the number of people who go, the length of time kids stay in school. And if you follow those kids for many, many years later, it turns out that those kids who stay in school longer, who actually have adequate schooling, they lead, they're of course more likely to work and have a good job, but they lead longer, healthier lives, because the poverty induced by lack of schooling leads to worse health. One estimate in the United States from the spring lockdowns, just the spring 2020 lockdowns alone, and the school closures, estimated that as a result of those school closures, American children lost 5.5 million life years in expectation. No one's done an estimate for India, but it's going to be on that order. Millions and millions of life years were stolen from our children, Krishna, as a result of the decision to close schools.
Yeah, I think this makes a lot of sense, because I remember reading Abhijit Banerjee's Poor Economics book, where he mentions about education in Africa, and how when the average people typically educated until 2nd grade in Africa, and I think in the early 2000s, when that went up to 5th grade, the life expectancy and the quality of lifestyle naturally shot up, because I think they have a better shot at employment and figuring out more employment opportunities in their life.
And the employment opportunities, it's not just employment. The point is that they have more human capital, they invest more in their health. It has a snowball effect on the health and quality of life, length of life. Schooling is the best investment we make as a society, the single most important investment, that with the highest return, because it prepares the next generation of people to live long, fulfilling lives and productive lives. It was a very short-sighted thing to do, even for the spring 2020, to close schools, especially since we knew that the risk to children was quite low from COVID. But to keep schools closed for 2 years is inexcusable, and I don't know how to get it back.
Have you particularly noticed any observation in the kind of grad students that you've picked up in the last 2 to 3 years as a consequence of them having to complete their junior or senior year of college through the COVID times?
So I've been teaching. I teach undergrads and grad students. Because we can talk about this, but like during the pandemic, because of my notoriety, because I was getting attacked so much, I didn't feel I felt like it was not responsible for me to take on a grad student and put them under the kind of like cloud of that I was facing. So I didn't take on new grad students during the pandemic. I taught undergraduates, and I didn't particularly notice a decrease in the quality of the students that I had as undergraduates, but I teach at Stanford, and so it's a very narrow view of the set of students what happened to students worldwide as a consequence of the pandemic.
Yeah, but again, speaking about the bash that you were facing, from being banned or from being censored on Twitter to now being on Twitter to Elon Musk following you, that there's been quite some haphazard curves happening there. What's been your experience through this?
Well,
because I remember particularly you mentioning on another podcast that you think it's not necessarily Twitter that's behind the censorship, and maybe in some level there's some kind of political pressure.
Yeah, so I think to understand what happened on social media, you have to go one step back, right? So Twitter, Facebook, all these entities, the social media entities that facilitate conversation and social connection on a whole range of issues, their fundamental economic interest isn't censorship. Their fundamental economic interest is actually free speech. And so the question is, why did they engage in such sharp censorship effort? Why did they restrict the conversation such that people who were saying things that were maybe even true things that were clear in the scientific evidence, like such as that if you've had COVID and recovered, you have substantial immunity? Why was Twitter, why was Facebook, why were they censoring people who were saying things like that, even true things? And the answer is that governments placed tremendous pressure on these companies to do that censorship. In the United States, let me tell you how I know this. And this is it sounds like a conspiracy theory with the way I say it, but it's not. And I'll tell you why I know this for a certainty. The state of Louisiana and Missouri, the attorney generals in those states sued the Biden administration with me and a few other scientists as party to that lawsuit. The lawsuit was about the suppression of online discussion by scientists at the behest of the Biden administration. So in this lawsuit, the federal judge allowed us to depose, meaning speak on record under oath with Tony Fauci, with a dozen other representatives of the Biden administration. And what we found was that there was a vast effort by the federal government to tell Twitter, to tell Facebook, to tell Google what to censor and who to censor. You can read the emails in the court filings from the government actors to the company, these companies, essentially threatening their ability to operate unless they acted on the government's demand for censorship. And people who were saying true things were censored. Posts that were saying scientifically verifiable facts, like I said, such as immunity after COVID recovery, were deemed as misinformation. I learned during this Twitter Files episode. So Twitter Files, what it really was Elon Musk bought Twitter last year in 2022, and he opened up the databases of Twitter to reporters. One reporter, Barry Weiss, she did a search for me and found in the database that I joined Twitter in September 2021. And the day I joined Twitter, I was placed on a blacklist, a trends blacklist. What that meant was that though I could tweet and my followers could see my tweets sometimes, there was no chance that my tweets would reach a much broader audience, which is the main purpose of my joining Twitter anyways. The reason I joined Twitter was essentially to tell the world about the Great Barrington Declaration, about the science of COVID. I wanted to reach an audience of people that didn't already know me.
But you mentioned you joined Twitter in September 2021. This is before the Barrington Declaration.
No, it's after. It's after. October 2020 is the
Oh yeah, 2020. My bad. Okay, yeah, sorry.
Yeah. No. I it's funny, Krishna, because like I told my I used to tell my graduate students and even the assistant professors in my department, just write papers, publish them on scientific journals. That's how you'll make a big impact in the world. Don't join Twitter. There's no purpose in it, I used to tell them. And now I find myself addicted to Twitter.
Yeah, you have close to 500,000 followers on Twitter.
Yeah, it's a tremendously important platform for reaching the public, for telling people about very important things. Huge numbers. It's not just the numbers of people, but also the type of people: journalists, legislators from around the world, religious authorities. It's the world's public square. It's how you can talk to people who both agree with you and disagree with you everywhere. I have a tremendous number of Indian followers. I have followers from Europe, the United States. It really, I feel the weight of being able to talk to so many interesting people. And I've learned a lot from Twitter, from the people on Twitter, like both about science and about policy. I mean, I think it's just it's a humbling place to be. I really enjoy it. And the key thing is that the conversation needs to be free. And really, until Elon Musk, it wasn't.
Very interesting. Before we dive deeper into Twitter, just a quick flashback again to the political pressure that we were speaking. Now, from a logical standpoint, it only makes sense that the government implemented the ideals within the Barrington Declaration because it's only going to improve the economy, if any. And if that is the case, it was in their best interest that they adhered to whatever you mentioned or whatever you suggested. But why do you think they took a contrary stance and told, it's better to block this guy off and let's continue to do what we're doing?
Well, I think for the answer to that, I think you have to try to understand the power structure that led to the decisions about lockdown during the pandemic. And of course, they're different in every country. I think in the United States, it was a relatively small number of very powerful scientists who fund other scientists that led the intellectual effort in favor of lockdowns. Worldwide, it was the World Health Organization. Again, a very small number of scientists who led that effort to try to tell the world that it needed to lock down.
What do they have to gain?
Well, I don't know that it's a question of gain. I think it's a question of a mistake.
Okay.
Yeah. So I think the Chinese in January of 2020 had an enormous outbreak of COVID in Wuhan and in the surrounding province. They imposed a draconian lockdown with movement limitations. They locked people into their apartment buildings so they couldn't come out. It was a mass violation of civil rights. And what happened was that the measured number of cases, although the Chinese definition of cases was quite different than the rest of the world, they weren't using the PCR test at that point. The measured number of cases dropped to 0 at the end of that January lockdown. At the same time, in February 2020, there was an enormous outbreak of cases in Bergamo, Italy, northern part of Italy. And there were media images of people, of older people dying in mass numbers, so much so that the undertakers couldn't manage the load. The caskets were lined up in churches. And so the World Health Organization in that context sent a mission to China, along with some of the top like World Health Organization epidemiologists, and including people like Cliff Lane, who was Tony Fauci's deputy. They came back from that mission to China. They never actually got to Wuhan. They just got to, I think, Beijing. They came back and wrote a report saying that the world needed to lock down. And that had a tremendous influence on world governments everywhere. That recommendation, I think, essentially changed the narrative in government after government away from the traditional management of respiratory virus pandemics, which were much more along the lines of the Great Barrington Declaration, toward a lockdown-focused policy. 2 weeks to flatten the curve was the mantra. And governments around the world complied with that.
So do you think collectively all governments around the world could have messed up at once in doing this? Or was it more along the lines of telling, okay, someone did this and everyone just followed suit and thought that must be the best approach without them having to apply much of their own, relevant economic justifications?
I think the second is true. I think that If you talk about economics, I mean, the Great Barrington Declaration, of course, is premised on public health. Like, it doesn't actually mention economics at all. That's not the primary motivation. It's actually the improvement of the health of the populations is the goal. The key thing, though, about that, if you remember back to March of 2020 and the debate around lockdowns, if you mentioned economics, if you mentioned the harms of lockdowns, people would shout you down. They would say, "Well, why do you care about money and not about lives?" Although, of course, the lives of poor people depends on being able to make a living. So governments around the world, that many of them had good economists to tell them, look, there's going to be tremendous harm, shut out those voices. The only voices that were allowed to speak really were virologists and immunologists and people who have particular expertise about viruses, but did not have a very broad vision about public health generally. And so that's what I'm saying. It's a very narrow group of scientists, and they're also very powerful scientists, Krishna. Because so just take in the United States, the Tony Fauci and the National Institute of Health and the National Institute of Allergy and Infectious Disease. The NIH controls $45 billion of money. That funds nearly every single biomedical scientist in the United States. And if you don't get funding by the NIH, it is very difficult to rise up in academic medicine, rise up the ladder in academic medicine. So I have a tenure at Stanford University in the School of Medicine. I needed to have an NIH grant in order to get tenure. That was a major way to show that my work was impactful.
Impactful, yeah.
And so it's not just money. That they control the status of scientists, the social status of scientists, which scientists care a lot about because it plays a role in where they can publish their work, how much support they can get from NIH and elsewhere. Many scientists, knowing the lockdowns were probably a bad idea, stayed silent because they didn't want to contradict scientific funders for whom they depended not only on for their research dollars, but also on their social status.
So do you think the Operation Warp Speed was progressive, or do you think it was a bad choice as well?
I would have in March of 2020, if you'd asked me, I would have said there's no chance that we're going to be able to get a vaccine in 9 months. That's probably one of the biggest mistakes I made during the pandemic. I did not think it was possible. Mainly, the reason I thought that was that there were the history of the development of vaccines. It takes years and years and years generally to develop an appropriate vaccine target, then to test it in animals, and then test it at scale in humans. Usually takes many years. So I thought it wouldn't be possible. But if I were president of the United States, I also would have supported Operation Warp Speed, simply because you have some very prominent scientists saying, look, this might be possible. And if it's possible and it works, well, then that means you may save a lot of lives. I think Operation Warp Speed was the right decision at the time.
Interesting. But again, I would want to go back to the Twitter episode here, right? Why are you so sure that Twitter would have had to do nothing by themselves in along the lines of censorship? And the reason I ask this is because there are quite a few reels or clips that we've seen going viral about a discussion. I think it's a Congress hearing where one of the Twitter representatives is being questioned by one of the congresspersons around why, if that particular Twitter representative is a healthcare professional, and if not, how do they have the right to censor healthcare professionals? So the Congress at that point seemed to be in favor of people who are voicing out their opinions and putting out different perspectives. And Twitter seemed to be the culprit, at least from these clips. And you seem to take a contrary, stance, and that's the reason I asked this again.
So I think I've seen that clip. It's the old Twitter lawyer, what's Gadi? I forget her first name. She gets asked by, I think, Representative Nancy Mace whether she's a doctor, and she has to say no, she's a lawyer.
Yeah, I think we're talking about the same clip.
Yeah. So that clip is interesting, and actually her actions are interesting. I think a lot of what happened at Twitter was tied up in the politics of the United States, and so the censorship efforts partly were motivated by political considerations. I mean, I think a lot of those executives were very much on the left, but I don't think that was primarily it. I mean, it's. I mean, you may be right, Krishna, that there may have been some efforts to censorship, but you can see even in that clip, what that Twitter lawyer does is she tries to say, look, we were just trying to do what the CDC was suggesting.
Right.
If the public health authorities and the government hadn't tried to tell social media, look, this is irresponsible to spread this message that immunity after COVID recovery might matter. I don't see how Twitter, because they don't have the scientific background, would ever have thought to themselves, oh, let's censor this message. There's a very interesting email from very early in the pandemic from Mark Zuckerberg to Tony Fauci. I think it's like February 2020. The Freedom of Information Act request reveals it. And in this email, Zuckerberg offers the help of Facebook to Tony Fauci in various ways. Now, some of that email is redacted, so it's not clear exactly what that help is, but if you but you can kind of infer what happened. The social media companies, which had been burned previously and criticized because they supposedly allowed election misinformation to spread, didn't want to be accused of that. And so they reached out to governments, and particularly the American government, and asked, help us censor the voices that contradict what you view as the science. So in a sense, you're right, Krishna, that it was partly the responsibility of these social media companies themselves, but I think that they were acting defensively. Like they were acting based on what the previous rounds of criticism they got for allowing too much free speech during, let's say the 2016 election or something. And they wanted to avoid that kind of criticism because, they face tremendous political threats, right? If they, in the United States, there's a law called the Communications Decency Act passed in 1996. There's a section of that act, Section 230 of that act. What that does is it allows social media companies to allow people to publish their thoughts, even if those thoughts are potentially slanderous or potentially libelous or something to somebody. The social media companies themselves are not liable. They're not considered a traditional publisher. They're just considered a communication vehicle that allows so that I might be able to write something that's just not true, that hurts somebody, and the social media companies aren't liable because of Section 230, right? Whereas if I write it in a book or write it in a newspaper, well, the newspaper can get sued for printing my libelous thoughts. So not that I would have any libelous thoughts. That's just an example. But yeah. So I think for the social media companies, they viewed their entire business model as under threat if they didn't do what the government wanted them to do, and they tried. I mean, they did what I think any reasonable executive in these companies would do. Is they tried to get ahead of try to understand what the government wanted from them, in order to comply even in advance, so there was no hint that they were not doing what the government wanted.
Yeah, it's a very interesting point that you're making in trying to say that they were just trying to play it safe and play defensive.
Yeah, I mean,
very interesting. And 3 years hence, do you think we've gained better scientific abilities to just progress better on drug research and prepare better in case of a future adversity?
So I think we can learn a lot of lessons from what happened here. So first of all, it's not clear. Well, okay, so I should go back and tell a little bit of history about pandemic preparedness here. So a lot of the pandemic preparedness infrastructure that we used during the COVID pandemic actually has its roots in biodefense and bioterror, anti-bioterror kinds of approaches. It goes back to, I think you have to go back to like 2001 and the anthrax scare in the United States, and then later the use of those kinds of that infrastructure to try to into civilian uses, right? So, for instance, in 2006, there was that H5N1 scare, or the avian flu scare, that didn't turn out to be much, but people were very scared, because if that H5N1 flu had jumped from birds to humans, it might have caused a lot of death. That led to a whole research line to try to essentially mutate viruses found out in the wild and see whether they had a potential for creating pandemics, like the sort of the famous gain of function work. In 2012, there was a breakthrough, and somebody, I think in the Netherlands, actually managed to succeed in mutating the H5N1 virus so that it could infect human cells in petri dishes. That led to and that was all part of the pandemic preparedness infrastructure, the biodefense infrastructure.
So you don't think there's some significant improvement in the capabilities that we have gained over the last 3 years?
No, I think I guess there's certainly been a increase in capabilities, but improvement is the question I'm trying to question. So, so in 2012, you have this technological ability to augment the function of viruses proven. There was a huge counter movement within the scientific community in opposition to this capacity, because it's potentially very dangerous, right? You're doing this research in laboratories. The laboratories, even high security laboratories, have a history of leaking. Leaking means, what does it really mean to a lab leak? It just means like a scientist or a lab worker, you're doing a lot of the work there is just pure drudgery. You're just like pipetting, and it's very easy to slip up and then get sick yourself. And then you go home and just spread it outside. That's what a lab leak really looks like. It's not like some nefarious thing where people are like secretly pulling a vial of bad stuff and spreading it around. It's just a bored lab worker gets sick because they weren't as careful as they ought to be when they're handling dangerous things. And then they go home and they spread it. That's what a lab leak looks like. And so people were very scared, like in the scientific community, that this kind of work, allowing this kind of work to happen, would increase the danger of that kind of lab leak happening. And so in the United States, there was a pause on that kind of support for that gain of function work by the NIH in 2014. That pause was lifted in 2017 at the behest of people like Tony Fauci, who was a big proponent of gain of function work. And it's quite likely that this pandemic was caused by such a lab leak. Because what happened was there was a huge research effort to go find the SARS viruses in bat caves in China and elsewhere, bring them into labs and see if they had pandemic potential. It's not a coincidence, I don't think, that the initial outbreak that caught the attention of the world was at Wuhan. That's where there's a major laboratory there that studies bat coronaviruses.
Right.
So, and I don't know for certain that it's a lab leak. There are still scientists who think that it wasn't. But I have to say, like, based on the emails and scientific evidence I've seen, it certainly seems like most scientists that work in the field at the time thought it was quite possible it was a lab leak, and that the ones who knew the best about it worked to cover up that possibility, suppress the public discussion that it could be a lab leak, to turn the idea of a lab leak into a conspiracy theory as opposed to a valid scientific hypothesis, which it absolutely was. In any case, I mean, whatever the result of that debate, I think the key thing is this kind of research work, this kind of pandemic preparedness work, gain of function work is actually dangerous. You don't even have to like do a theoretical thing. In late 2021, there was a high security lab in Taiwan studying the SARS-CoV-2 virus, the virus that causes COVID. And there was a documented lab leak in late 2021 from a high security lab in Taiwan. The possibility of a lab leak with highly infectious agents like this is incredibly high. And so whatever knowledge you gain from this kind of research, you have to offset against the increased risk that you may in fact cause the pandemic that you're trying to prevent.
Very intriguing. So do you think, I mean, I gather that gain of function research can be super risky, but what do you think is the future of this space? Because I don't think it's going to stop anytime soon, because the interest in gain of function research, if any, is logically likely to increase over time.
I think there's going to be if you're asking me to predict the future, I'm generally very bad at that, but let me try.
Okay.
I think there will ultimately be an international treaty banning that work. Just as the way that there's an international treaty that bans nuclear testing, there will be a similar international treaty because the world community will deem that kind of research too dangerous to allow. And I think the current status of gain of function work, it's still happening, absolutely. But it's because the set of people who were promoting it before the pandemic are still in charge of the scientific institutions that decide whether to support it. I don't think that situation will last forever. And the next generation of leaders that will come into power in those scientific institutions will not support it. And then the reason is simple. It's because the world is beginning to understand how dangerous that line of research actually is. And once the public starts to understand that, it will demand an international stop to this kind of research.
So despite it being so risky, what is possibly enticing about it that's exciting for the existing hierarchy, or for the existing leaders to promote more of it?
Well, so let's go back to 2012 and that H5N1 gain of function.
The bird flu thing, yeah.
What happened there? What was really interesting was that you could look at the number of mutations or something that was needed to turn something like the H5N1 virus, which mainly infects birds, and then see how easy was it for it to evolve into something that could infect humans. Right. So first, then that means you could predict which viruses are likely to make the jump. Some viruses need many mutations that are very unlikely to happen in nature, so we don't need to worry about them so much. Right. So that's one. You gain that knowledge. The second, you identify essentially weak points of the virus or the pathogen that are amenable to treatment or vaccines. And you do it before the virus or the pathogen spreads widely. So you have in your armamentarium things that allow you to address the threat and research the threat even before it happens. That's the promise of gain of function research. That's why these scientific, they're not irresponsible. They're not like mad scientists who just want to know knowledge for its own sake. There was a practical reason they were giving for why this gain of function work needed to happen. And actually, you might even be able to point to the Operation Warp Speed as a kind of success of gain of function work, right? We knew the vaccine, the target of the vaccine almost immediately. I think by early January 2020, we already knew what the vaccine should target, the spike protein. And how did we know that? It's because we've been studying this for decades. We've been not this particular virus, but viruses very similar to it, in part because of that gain of function research agenda. So, in a sense, you have a real trade-off here. I know how I would manage the trade-off, but you can see other people maybe would manage it differently. You have a virus that is spreading around the world that may very well have been caused by a research agenda that scientists like Tony Fauci supported. But at the same time, you have the countermeasure already developed as a result of that research program. Now the problem is that it's not enough with a vaccine to know the vaccine target. You may have a theory about it. The gain of function work at best provides you a hypothesis about what the vaccine target should be. You still need to test it. And you need to test it not only on animals to make sure it's relatively safe enough, but also the vaccine produced by it is safe enough. You also need to test it at scale on humans for a long period of time, right? So this vaccine, we had a randomized trial, a pretty good randomized trial that was done within 9 months. Several randomized trials actually were done within 9 months of like by just or 12 months. But December of 2020, we had published randomized trials with tens of thousands of participants. The problem was those participants were only followed for 2 months. The randomized trial told us that there was a prevention of symptomatic infection, but it didn't tell us that it prevented severe disease, the vaccine, although I think it probably did, especially in older people. That also didn't tell us if the vaccine stopped you from getting COVID. It didn't say all, it didn't test for whether it prevented all infections, and it only tested for 2 months. As it turns out, the vaccine doesn't stop you from getting COVID. After about 3 or 4 months, the efficacy against infection drops very sharply. And of course, the vaccine is only against the original Wuhan variant, not against the variants that are now circulating. So that means the trials, who knows if the trials that were done in 2020 really apply at scale to the current variants that are spreading. That's why it normally takes years, not just because of the biomedical, the sort of the biochemical work or the molecular biological work to decide what the right vaccine target is, but to test at scale in human populations to try to see the proper use of the vaccines, side effect profiles, so on, and then make decisions. That's a very complicated thing, and that's why it normally takes decades.
Interesting. And in this entire episode, do you think media, as in traditional media, press, had a significant influence on how people perceived the entire episodes through the pandemic? Do you think media did something right or wrong through the
I think the media
period?
Was terrible. I think the key and probably the cardinal sin was that the media amplified panic and fear. They suppressed voices that would not just suppress but demonize voices that would that conveyed calm, and amplified voices that conveyed the threat and harm from from infection by the virus.
And why do you think that is?
I mean, I think most media, and even this includes most science writers in media, do not really understand science or how it works. Right? Okay. Science doesn't operate by consensus. Science operates by logic, evidence, debate, alternate hypotheses. Science operates with a very different process than I think most media people writing about science think operate. Second, I think a lot of media, especially the most prominent media sources, they rely on high government official sources in order to get to be able to write things that other people wouldn't be able to say. Right. So Tony Fauci is a very important source for some of the most prominent science reporters. And if they cross Tony Fauci, if they say something that's critical of him, he won't talk to them. And
so it's a question of survival for the media.
Yeah. And so then the other thing is the media interests themselves also have I mean, the media companies did really well during the pandemic. Panic sells. Calm doesn't. So I think the media companies as a whole really harmed the public health during the pandemic, both by fear mongering and then later by spreading essentially an idea that this distinction between clean and unclean. So the media spread the idea that if you had COVID, you're unclean. Spread the idea that if you're unvaccinated, you're unclean. They divided the population with their messaging, and suppressed the public attention on lockdown harms that would, I think, had they been prominently displayed as prominently displayed as the harms from COVID would have gripped the public imagination. Right, hundreds of thousands of children dying of starvation in South Asia, that needed to be at the forefront of public imagination. 4 million kids in Uganda never coming back to school after 2 years of essentially no school, many of whom sold into sexual slavery, especially little girls, because the parents were so poor that they couldn't afford to feed their families. That needed to be at the forefront of public imagination. The media mentions it, but it very, as if it were like a second, a second thought rather than a primary thing as a result of the policies we followed. The media misled the public during the pandemic.
Do you think they were also trying to hide the actual numbers or not reveal the actual data regarding be it the number of deaths or be it the number of recoveries?
Well, I mean, I think part of that's the fault of public health, right? So the public health, the way that public health authorities defined a COVID death was very, very broad, out of line with normal. So for instance, you could have a heart attack, but if you also happen to have COVID at the time, many places would count that as a COVID death, even though it was the heart attack that killed you.
Mm-hmm.
So many people who especially for younger people who incidentally had COVID, but then died of something else, were counted as COVID deaths. There was an autopsy study in Santa Clara County, California, where I live, that estimated that 25% of people who were counted as dying as a result of COVID, actually COVID was just incidental in the death. We overcounted COVID cases. The PCR test was used at scale in ways that I think were tended to. There's some technical issues here, but like the PCR test can be tuned to be more or less sensitive and more or less specific. The idea meaning that if I tune the PCR test to pick up even small fragments of the virus, the viruses that can't replicate in human cells, I would count you as a case if I tune it that way. I could tune it to where it wouldn't pick up those kinds of fragments. I would only be positive. It would only be positive if you have virus that's capable of replicating. Public health chose to tune it so that it would pick up even small fragments that were not capable of replicating. And so as a result, we overcounted COVID cases.
Would it be, sorry to interrupt you there, but do you think would it be fair to give a benefit of doubt and tell that the reason they would fine tune the RT-PCR is just to make sure that even the remotest possibilities are eliminated?
Well, why? What's the public health purpose of that? So if your idea is that anyone who's even remotely possible may have COVID, even if they're very unlikely to, should quarantine for 2 weeks and lock down. Okay, maybe. But the problem is that's not possible for most people of the world. And there are sort of counter things that happen as a result of that, right? So you have this whole test and trace regimen. So if someone tests positive, there's the test and trace people come, they ask who you were around, and then they quarantine, they recommend quarantining anyone you came in contact with, right? Well, what incentives do people have? You got to feed your family. If I test, there's some possibility that I'm going to be positive, even though I have no symptoms. Even though it's really unlikely, and I'm going to have to quarantine for 2 weeks, even though I'm young, and it's really unlikely that I'm going to die from this thing. And that means that, or longer, my friends are going to treat me like I'm a pariah. Well, I'm just not going to test. I don't want to risk that. The test and trace thing is whenever there was a huge uptick in cases, every single test and trace capacity in the world got overwhelmed. It would take weeks to get back to somebody who was positive in some places, like in LA County is a good example of this. And so they ask, okay, where were you 3 weeks ago when you got COVID? Oh, I went to a grocery store. Well, who was in the grocery store with you? Well, I don't know. How am I supposed to know who was in the grocery store with me? And it happened 3 weeks ago. If those cases are no longer preventable, right? Those cases, if they happened 3 weeks ago. What was the purpose of the test and trace? The whole ideology of test and trace and quarantine and lockdown, that whole ideology, the testing decision about the sensitivity, where sensitivity to testing was made in support of that ideology. Now, suppose instead the testing had been used for focused protection, then what would have happened is that we would have had at-home rapid antigen tests much earlier in the pandemic. We could have told people, well, before you go visit grandma, it might be wise to get tested. Test yourself quickly at home, privately, and then you can make your own private decision. Don't go visit grandma if you're positive would be the recommendation, but you wouldn't be forced. You could have used tests much more efficiently in nursing home settings, right? The PCR tests early in the pandemic would often take days to get back the result, 1, 2, 3 days to get back the results. Well, you want someone who's going to go work in a nursing home, you really want it to take 3 days before you know they're negative, before you allow them to go into the nursing home? You want a rapid test. The problem was the testing was used in support of this test and trace ideology, this lockdown ideology, rather than used in support of focused protection. And all of the decisions about the sensitivity, the specificity, all of those decisions or design parameters of the tests were tuned in support of the lockdown ideology rather than in support of focused protection of vulnerable people.
Yes, so largely it's about telling that since we try to be too sensitive with it, we actually created more fear-mongering among the public, and then that must have prevented a lot of people from getting tested, although they might have been potential carriers of the virus.
Yeah, I think that whole ideology was a fail. It was failed, and for media companies, it was great. Like they could put up those maps that looked like video games, like big red circles spreading here and there. They could give things that looked like science, numbers of cases, projections that were rooted in data that were really, where people didn't understand the limitations of the data they were analyzing.
Yeah, and I think the way they presented it could be highly questionable. For instance, if the cases doubled from 200 to 400, and you said that the cases doubled, it sounds like a serious problem, but 400 is an insignificant number.
I mean, the disease spreads very easily, Krishna. That's just a fact, right? We have the main, if you had to put a central sin to the whole thing, it's that we had this illusion of control. We think our science is so good, our social policy is so powerful that we can stop the tide from coming in. That's what it's akin to. We don't have the kind of control we think we have, and we certainly, it should be clear to everyone now. Did the lockdowns work? I told you that seroprevalence study in Mumbai found 70% spread in the slums by July of 2020. What purpose was the lockdown? What did it actually serve to accomplish in India? What did it accomplish anywhere? The disease spread everywhere anyways. What the best we could have done was protect vulnerable people, vulnerable older people, by devoting resources, giving good advice, developing tools to protect vulnerable older people. And we've often failed to do that because we didn't have that as a priority. We sent COVID-infected patients back to nursing homes because we thought keeping hospitals empty was the priority. I mean, if we had oriented ourselves around protection of vulnerable people, many people would be alive today that are now dead.
Very interesting. I want to switch gears here. I was reading about a recent article that you wrote around the impact of income inequalities on and the prevalence of, I think, infectious diseases. So just want to understand a bit deeper around what your thoughts around this are. Do you think that being at the bottom strata of the economic, being at the bottom of the economic strata prevents you from not just access to primary healthcare, but also healthcare for chronic diseases?
Oh, I mean, being poor is terrible for your health in many mechanisms. Certainly access to care is one mechanism. If you especially look from a worldwide perspective, the poor have by far the worst health. A part of the problem is, of course, is because you have limited resources, it's hard to devote the limited resources you have to things that richer people take for granted: better nutrition, time to exercise, things like that would normally the richer people often take for granted. Poor people have no capacity to invest in it. So from especially from a worldwide perspective, the paper that I think you're talking about is this paper about tuberculosis. The argument there is that if you have an unequal society, an infectious disease spreads in part because, like tuberculosis spreads because the living circumstances of the poorest people guarantee that there's no way to shield yourself from it. And you have a more unequal society, you'll have a greater number of people in poverty who have no ability to protect themselves, and the disease then will take hold in the population and spread. And especially if there's population mixing between poor and rich, which in India that happens quite a lot actually. The disease will be almost impossible to decrease to low levels. Whereas more equal societies where the poorest populations are richer, it would be more difficult for those diseases to spread. And so in that paper, we test this hypothesis by looking at a country level. It's a correlational study, so it's not. I mean, I don't know how you'd run a randomized study on this, but like it's suggestive. Richer society, like more unequal societies, have higher prevalence and spread of tuberculosis. On the other hand, if you look at diseases that are not spread communicably, diseases like diabetes or something that are spread, it's a metabolic condition, that the connection with inequality is much less.
Oh, very intriguing. Okay. Because the reason I say it's intriguing is because I think we would, as a layman, I presume conditions like diabetes or hypertension is largely a function of lifestyle. And by and large, we kind of living the urban lifestyles that we do, I think we're more prone to these conditions as opposed to someone who might be poorer but might be leading a healthier lifestyle in terms of how their physical activities might be and how their metabolic activities might be.
Yeah, I mean, I think the incidence of diabetes is certainly it's a metabolic condition, and I think South Asians in particular, I think we have some predisposition toward diabetes if we live richer lifestyles. The rates in the United States, for instance, the rates of diabetes are higher among South Asians than among the population at large. Whereas if diabetes prevalence among the poorest of the world, take India, for example, is actually quite low. So there is a lot of inequality in diabetes incidence. But if you look across countries, the countries that have more more inequality in income do not necessarily have higher diabetes rates. The richer countries have higher diabetes rates, but holding fixed the income level, the countries that are more unequal are not more likely to be diabetic. On the other hand, the countries holding fixed income levels, the countries that are more unequal do have higher tuberculosis rates. And I think it's a general theme, Krishna. The key thing is when you think about disease, it's very tempting to think about it simply as a biomedical phenomenon, but it's not actually just a biomedical phenomenon. It's actually a deeply social phenomenon. Poverty makes disease worse, more disease likely, makes more diseases happen. When we undertake policies that increase poverty, that increase the hardship of people living at the bottom of income distributions, it makes the lives not just of them worse, but everybody worse. And that's the argument for investing in health for the poor. I mean, there are moral arguments as well, but that's I would say an economic argument for investing in health. I think for me, the lockdowns and the policies we followed during COVID violated that basic principle, both an economic principle and an ethical principle. We should have been thinking about the poorest, the most vulnerable in our responses. And instead, what we adopted were policies designed to help the richest, the laptop class. What we adopted, if I'm going to characterize the policy we adopted, it was a policy of focused protection of the laptop class. It's a kind of trickle-down epidemiology. The theory was, what we'll do is we'll protect the laptop class by these lockdowns. And by osmosis, by trickle down, it'll help everybody. Well, that's not true. It didn't help everybody. What it ended up doing is harming some of the very, very most vulnerable people in the world.
So, I'm just trying to process what you just mentioned. And as a consequence of this, do you think universal basic income is more effective in combating such income inequalities and the consequences of that and how we are able to afford healthcare? Or do you think something like universal health coverage is more impactful?
I think the second is likely even more impactful. I think in terms of if you're just purely health, there are some like randomized studies. There's a study called Progressa where they try to answer questions like this. Like I think it's in Mexico. They randomly assign people. Some people get income, and some people get conditional cash transfers where they have to like sit in healthcare classes or whatnot. I don't know if it directly speaks to this, but as a general matter, I think if you want people to invest in health, it's not so much that you make transfers. What you need is social conditions that address poverty, that make poverty less likely. That's why I've said earlier about schooling. I think the single best thing you can do for poverty and the poor, the health of the poor over the long run is invest in schooling of children. Poor children everywhere deserve the capacity to develop their human capital so that they can live long, fulfilling, healthy lives. That's probably if I like just giving money to poor families. I'm not against it, but I think if that the best way to spend that money is actually education. It's but it has to be effective education, right? Something that actually increases the social opportunities of the poorest children, so that everyone has the same kind of access to education that maybe you and I have had access to.
Okay, I just want to do a thought experiment here. Suppose we hypothetically, improve the educational policies and access to better quality education, and maybe in 5 years we see, a sudden growth in the number of people that come out with certain level of capabilities and skills. How do we suddenly compensate for the sudden, growth in the job market on the demand side? How do we provide for the opportunities for them? How do we suddenly create these many more avenues where people can explore, full-time working options?
See, I don't think of that, Krishna, as a zero-sum game. I think that when you have a population, I think there's a range of demands, some of which has to be met whether you have an educated population or not. People have to grow food, people have to take care of sanitation systems. If the supply of those people wanting to do those jobs decreases, then what will happen is the wages for those will increase. It'll equilibrate. So I don't worry so much around that. So I don't think it's a zero-sum game. I think what will happen is, and this is, I think you can make the same argument with AI, for instance. AI augmenting the capacity for high-skilled workers to do their work. Well, then what you'll do is you have a different nature of work that better meets the demands of the population with a workforce that's capable of doing it. I don't think what will happen is mass unemployment. You have a lot of people with a lot of skills that people find valuable. People will find ways to use it. The market will find ways to use it. It's hard to project into the future exactly what that would look like, because of course many things can happen in between, and the markets are not perfect, obviously. But I worry less about that than I worry about a very large number of poor people with very few human capital skills living their lives in poverty. I think that's the worst outcome that we could have. It's what we have, of course.
So speaking of AI, how do you think AI is influencing research in the world of medicine? As a professor of medicine, how do you think it's changing the way you look at things?
So let me tell you a little story from the mid-90s when I was in medical school.
Okay.
So one of the things that you have to learn in medical school is something called a differential diagnosis. You have a patient who has a set of symptoms. You don't know what's causing that set of symptoms. You want to get the underlying diagnosis. Use the scientific method. You say, okay, well, here are 7 ideas for what might be causing this set of symptoms. And once you have that's called a differential diagnosis list, and then you conduct tests to distinguish between the different diagnoses, excluding things one after the other until you're left with just one saying, okay, well, this is what's causing this patient's illness, right? That's a pretty common exercise in medical school. You learn how to do that. It's a pretty common exercise in medicine. It's a scientific method applied to medicine. In the mid 90s, there wasn't ChatGPT. There wasn't there wasn't even Google. What there was these databases of medical articles. You can still access them. PubMed is where every single peer-reviewed biomedical journal is indexed in PubMed. So what I would do when I would get these exercises, I would type into PubMed the set of symptoms: fever, cough, lymphadenopathy, whatever the set of symptoms that my teachers would give me. And then I would get a list of papers. The list of papers would have those symptoms in the papers, right, as keywords or in text. But the titles of the papers would say what the diagnosis was that led to those symptoms. So just by looking at the titles of those papers, I could get a very complete list of a differential diagnosis list. That's an AI system. That is an AI system, right?
Right.
It's essentially what ChatGPT potentially could serve as is just like that. It could help doctors make better informed decisions. Now, you still need judgment of doctors. You still need the experience of doctors. The AI systems still don't replace that. The AI systems don't replace the fact that you still have to talk to patients and understand where they're coming from, what they really want with their life. You still need, there's still like this human touch that's, I think, quite important to medicine. I don't think AI systems replace that. But they do help doctors be more accurate in their thinking, to think more scientifically, at least in principle. That's how I view the future of AI in medicine.
Interesting. And with AI sort of penetrating clinics, do you think the cost of treatment is likely to go up or down? Of course, the efficiency might go up because, like you rightly mentioned, maybe much of the work that was otherwise being done by a human in terms of diagnosis, maybe a system is able to do it more effectively and faster for you. But how does it translate into the cost of healthcare?
See, I don't know that the AI system does the diagnosis. The diagnosis often is not just the different, like you don't just type in list of symptoms, get a differential diagnosis. You still have to like work through the scientific method to get to like what, and then you have to deal with the fact that you have a patient in front of you and their symptoms change, and it's much more complicated. But I do think that AI systems can help doctors do better with that, and with those processes. I think that the key thing is that I think those AI systems lower the cost of entry to becoming an excellent doctor. And so what that means is you'll have a higher supply of excellent doctors, potentially meaning a lower price of excellent, more competition among excellent doctors. So I think that what it does is it's from a theoretical perspective, one model might say that it actually reduces the wages of doctors. Now, of course, at the same time, the doctors are doing more valuable things, right? They're more efficient and less likely to be error prone, so the demand might also go up. So it's ambiguous exactly what effect it will have on the price. I do think it's pretty exciting. I mean, I think that the idea that you can use these systems to augment our capacities to do medicine bodes very well for the future.
Interesting. I want to tie this back to another article that I think I read recently, where you mentioned that the operating margins have been dropping significantly over the last decade, at least in California hospitals.
Yeah.
What do you think has been the biggest contributor to this? And do you sort of see this trend continuing into the future? And does AI affect this trend in any manner at all?
Well, I think the operating margins in California, that has more to do with government policy. In particular, how governments pay for the care for the poor and how the governments pay for the care for the elderly.
So it's mostly to do with public hospitals and not private hospitals?
Well, so in the United States, governments pay for care in private hospitals as well. It has to do with the people, right? So like it has to do with like poor people get care through Medicaid, which is a government-funded, state government-funded program, and federal government program. And older people get care through Medicare, also federal government funded. And you can get care at any hospital with Medicare, for instance, or almost any hospital. the operating margins in part, so a part has to do with the sort of declining the rate of payment, the amount of payment for services by government payers has been gotten lower as a fraction of what private payers are willing to give. At the same time, hospitals have become, I don't think have become very efficient. Like, you know, a lot of times you see businesses in tech or whatever becoming more efficient over time. Not always, or at least the market becomes more efficient. So you get small startups that are nimble, that can do things more efficiently. That's how you take down big companies, right? So the market as a whole becomes more efficient. I don't think you can say that about hospitals and doctors in the last 2 or 3 decades. In many ways, hospitals and doctors have become less efficient. There are incentives in place to adopt services and care that doesn't provide a lot of benefit to patients, but are very, very expensive, because third-party payment essentially shields patients from the cost of that. And so what you have is a sort of a declining market, a market that's not been particularly efficient, becoming less efficient, and you have government payers saying, "Look, we don't want to pay for this," and that's why you get the declining operating margins. Now,
So
that's one theory.
in a way, are you saying that it's because the quality of the healthcare service itself is declining?
Not that the quality is declining, that the marginal increase in quality is paid for at a very, very high cost.
Okay.
So it's not that the quality is declining; it's just that the cost efficiency is declining, right? So you have higher quality care. It's just that the marginal improvement in the quality of care is so expensive that it's not worth it to many payers, right? So like other countries deal with that by technology assessment, for instance. Like in the UK, for instance, there's a body called NICE, or the what's it called, the National Institute for Clinical Excellence, which assesses the cost effectiveness of every single new technology, or the most new technologies, and then makes recommendations to the government to whether the NHS should adopt it. The United States doesn't have such a system, but there are very strong incentives in American medicine to adopt new drugs or new procedures that provide very small additional marginal benefit to patients relative to the existing procedures, but cost a lot more. And there really isn't, like, normally you would think insurers and payers would stop that from happening, because it's really ultimately consumers that pay for that. But you don't really see that. The market doesn't really serve that purpose as effectively as one might think in the United States. Public payers have very limited budgets, restricted budgets. Like there's only so much you can raise taxes. And yeah, you could borrow deficits, but indefinitely, I mean, as the population ages. And so what's happened over time is that the public payers are not paying rate increases that are commensurate with the increasing expenditures of healthcare in the United States. And that's why you're seeing some of these operating margins shrink.
Interesting. Extrapolating this conversation, do you, at least it seems to me like there's a growing interest in primary healthcare across the world. Do you agree with the view, and do you think primary healthcare deserves more attention than the more serious ones?
I mean, I think in one sense, absolutely. We talked about some at the beginning of this podcast, right? So, for instance, the investment in vaccines for children, like DPT or MMR, is tremendously valuable primary healthcare intervention. And the other primary interventions, like in more developed countries, like cancer screening, even in poorer countries, like cancer screening, I think are tremendously valuable. You have to be careful, though, like not just because it's a primary intervention or primary intervention doesn't necessarily mean that it's worth it, right? So, for instance, I don't think that the vaccine for COVID is worth it at scale for younger people. The benefit is relatively small, and the side effects are there, especially young men like you have a relatively high rate of myocarditis from the vaccine, from the COVID vaccine. So it is a primary prevention kind of thing, but it lasts maybe 2 or 3 months preventing you from getting the disease with this offsetting harm. So it's not that I guess I'd say I am in favor of primary prevention efforts that make sense, that pass evidence-based medicine tests.
Okay.
Not something as a general thing, but as a specific thing, prevention by prevention, like item by item by item. You have to do. There's no, just because it's prevention doesn't mean you still don't have to do careful analysis to see if it's worth it.
So do you think preventive healthcare largely also ties with diagnosis, in sense that you're trying to diagnose things early, and think about something like maybe you're borderline diabetic, and maybe you need to pay more attention to how you deal with your food and diet, and just maybe how much you walk or run in a day and stuff like that? Or do you think preventive healthcare is disjoint from some sort of early diagnosis?
Yeah, I mean, I think, well, I mean, sometimes it's just early diagnosis, right? So, like, I mean, the metabolic syndrome is a good example of that. But there's some things you can do if you learn early that there's some that you're prone to getting diabetes. In other cases, it's harder to say, right? So, for instance, there are biomarkers for Alzheimer's disease that indicate a right-shifted probability of developing Alzheimer's disease many years in the future.
Mm-hmm.
Is that helpful? Especially since there's not much you can do to prevent it. Or genes that say, well, look, you've increased odds of getting breast cancer. Well, okay, you can like have a mastectomy now, but it's very likely you probably wouldn't get breast cancer, even though the odds are bigger than someone who doesn't have that particular gene mutation. So the question then is, with that information, what would you do? Is it worth it to know early? The answer is sometimes yes and sometimes no. It really just depends on the availability of treatment, how you would react to it, the accuracy of the test and the prediction. It's a complicated question. So to say prevention yes, prevention no, it's not a binary thing across all preventive measures. It I think is an item by item question, whether it's beneficial for the lives of people to know early. Is it worth the costs? All those questions still need to be asked, even though it's prevention.
Very interesting. As a doctor, what do you think are some, maybe not as a doctor, but as a professor of medicine, what do you think are some things maybe the world is doing right or wrong when it comes to just healthcare in general right now? World isn't not at the policy level, but at individual level.
Well, I mean, we've already talked about what I think we've done wrong during COVID. Tremendous mistakes. On the other hand, I think we've seen tremendous growth in the knowledge in biomedicine and the development of new products and drugs. It is definitely like heartening to see that. I guess the criticism I'd have is that we actually are too conservative in our investments in biomedicine. We often make investments in biomedicine research that are just one small step beyond, like you have a cancer drug, you make some small minor modification to it, and then you run a long time randomized trial in order to see if it works and produces 1 month extra. We don't invest enough in transformative science.
Mm-hmm.
Risky science, that risky not in the sense of like threatening the public, but risky in the sense of like maybe it'll fail if I do this. We don't invest enough in part because of the structure of the way we fund scientific research. It favors existing paradigms and doesn't really. It's not like the startup world in the 90s in tech. Huge investments in very, very risky things, some of which paid off and most of which didn't. But as a result, we have an enormous transformation in how tech works, right? From those investments in the 90s and 2000s, 2010s. The pace of improvement is even as Moore's law slowed down and you didn't get a doubling in chip speed, you get huge improvements in capacities. Like the AI revolution of just the last year is just amazing to watch. In medicine, I thought I've been in medicine now for almost 30 some years, and from medical school on, I would have thought there would be much more advances, many more advances than there have been. And we sequenced the human genome, but what real treatments have come out of that? Many fewer than I would have thought. A lot of what medicine that I learned in the mid 90s in medical school, really what's happened is an undoing rather than an addition, right? So a good example of this is in medical school in the 1990s, I was taught about stomach ulcers as primarily caused by stress, potential bad diet, and so on. And so like people would treat it with, essentially things that didn't really work very well, or sometimes very invasive surgeries. Whereas really what turns out the key thing was that it's this pathogen, H. pylori, that causes many stomach ulcers. That's a real advance. That advance took a very brave set of scientists a long time to get established in the scientific community. Biomedicine seems very resistant to that kind of radical transformation, and that was an addition by subtraction, right? That we took away this old theory and replaced it with a correct theory. It's the pace of advance. It's not that there aren't advances happening. It's just, for me, I look at it and it seems to me the pace of advance is much slower than, for instance, my friends who entered, Silicon Valley.
So when you say the pace is slower compared to what might be the advances in, let's say, semiconductors or computing and stuff like that, or big data, do you think it's largely due to private capital at play? And if that is the case, do you think if startups had a better shot at solving some of the open problems in medicine in general, maybe the pace of advance would be faster? And if so, what do you think are some open problems that startups could solve?
Okay, so I think the investments in research in biomedicine the government plays, especially the United States government, plays an enormously important role, right? So the kind of science that's done that has a shot at entering the big journals is science that's supported by the NIH or the Wellcome Trust in the UK, or just a few big funders. A lot of it, like some of it philanthropy, a lot of it government funders, and those funders are dominated by people who are already successful scientists, and as a result, they tend to be much more conservative than they kind of ought to be from a from social optimum perspective. There needs to be more turnover in scientific. There need to be many more of these like H. pylori kind of breakthroughs in science and biomedicine. The private systems, like the startups and all that in biomedicine, very often are what they have as their hope the production of a single product that they want to be bought up by a drug company or something. It's not fundamental science, it's an application of the existing scientific ideas. I think the whole infrastructure is set up to discourage radical change in the same way that very unlike radical change that happens in computing markets all the time, right? So in the mid 90s, it was Microsoft was a monolithic monopoly that could not ever be displaced. Then Google comes along and destroys it. And now you have ChatGPT. I mean, I don't know, if I were Google, I'd be very scared. So I think the kind of radical shifts and investments in thinking that characterize so much of the rest of the technology world has been much slower in biomedicine. I'm not to say there haven't been advances, like there's CRISPR technologies and so on. I don't know if they'll have clinical uses necessarily. That takes a long time to decide that. But the rate of change has been much slower than in other areas. And I think there are systematic reasons for that in how we fund biomedical research that make it automatically more conservative than it ought to be.
Okay, very interesting. I'll maybe switch gears here, and I want to delve a little into your personal thoughts here. Speaking specifically of mental health, do you think it's largely a clinical problem, or is it a social problem?
It's both. It's both.
Okay.
Mental health generally depends on the context in which you live. Like, so let's just take something like depression, right? It is many times it's a clinical problem. You can address it with antidepressants, but many times the context of where you live, your social circumstances, your network of friendships, how lonely you are, how disconnected you are, plays a tremendously important role. It's a very complex phenomenon that's both. And just so I'm clear, the fact that it is a social phenomenon doesn't make it not real. Sometimes people think of it as, oh, if I have a mental illness that's treatable by altering my brain chemistry with a drug, therefore that's real. Whereas if I have a mental, like a condition like depression that only is treated by changes in my social living circumstances, that's not real. That's all in my mind. I think that's a false dichotomy. I think both are really, really important contributors to mental well-being, potentially. I think the role of drugs generally ought to be limited, but when it's necessary, it's necessary, and there's no shame in it.
So when you say that conditions arising out of social circumstances are maybe as real as the clinical conditions, I just want to extrapolate this a bit. As a medical professional, do you ever think of questions like what exactly is happiness, or how do we define satisfaction, or what exactly is loneliness? What results into us feeling bothered about some of these circumstances?
I think people are very complicated. We don't really have so the answers to your questions are I guess, if I'm going to be completely honest, is I don't know. I don't think anyone really deeply knows. Those are questions that are at the heart of what it means to be human, right? Mm-hmm. What is our purpose in life? How do we fit into this the lives of others? What can we do to help others in their lives? What help can we get from others when we need it? To how can we love each other? Those are all like deep questions about life that everyone answers, I think, in differently given their own individual circumstances. Medicine is only a small part of that, actually. I think, and mental well-being. I think thinking about medicine as providing answers to all those questions is looking for help in the wrong places. It can help, and especially when they're like well understood dislocations having to do with depression is a good example of it. Like a deep depression that lasts a long time often can be treated with antidepressants correctly, but it's never sufficient. There's always going to be other things that you're going to have to happen that are outside of the possibility for medicine to fix. Because what you're talking about is something medicine is only one small part of your health and well-being, right? And to think about it as the main part is definitely a mistake.
Very interesting. And just a little bit about your past, Professor. What was the point of inflection when you decided you want to get into medicine and this is what you wanted to do for your career?
Well, I was born in Calcutta. It was Calcutta then. I guess it's called Kolkata now. My mom grew up in a slum in Calcutta. And when I was little, we would come back to visit. I came to the United States when I was 4. My parents immigrated with me when I was 4 years old. But we come back to visit family very, very often, every few years. And I remember one visit when I was 18. I was reading a newspaper in Calcutta, and it had made the point that the number one cause of child death was diarrhea. And it was, cholera, other, and this was a treatable condition. What you do is you give a 10-cent solution of salt, oral rehydration solution, put it in water, and then then you just give it to the kids and they don't die of diarrhea.
Right.
That shocked me. I mean, I always was good at science, and I kind of always wanted to be a doctor in some ways, but like that solidified. And I wrote my medical school essay, my application essay, so around that point about what medicine can do. 10 cents and you save the life of a child. I mean, why do we not make that investment? That still is true today, by the way. Huge numbers of children die of diarrhea.
Oh, really? Okay.
Yeah, I still think that medicine can make a big impact, and that's when I decided I wanted to do medicine. But I also was attracted to economics because my PhD's in economics, because it seemed to me that if you really wanted to understand health and make a difference in the lives of people, you needed to understand the trade-offs, the constraints that people face, especially the most vulnerable people. And so that's sort of how I mean, like sort of bigger perspective, how I ended up where I am. I mean, to me, it seems so connected. You have to understand the economics of the poorest, the most vulnerable, in order to understand their health. And medicine is, of course, a tremendously important way of thinking about improving people's health.
Very interesting. And there's a question I asked to everyone on my podcast. What would you be doing today if you were a 22, 23-year-old out of college?
I think I'd probably do the same thing. I love what I do. Although the last 3 years have been very difficult, I still love what I do. It's been a great privilege to be able to participate in very, very important conversations around worldwide about how to improve the health and well-being of vulnerable people. And I don't think I'd change that.
Very interesting. Thank you. Thanks a lot for this, I think, elaborate conversation, Professor Jay. This has been super insightful for me. Thank you for this.
Thank you, Krishna. Thank you for inviting me. So wonderful to talk with you.
Yeah, my pleasure.